we have the 3 subclasses for class 2, 3, and 4, but not for class 1. So if we come back to our decision-making process when we have soft tissue dehiscence, we have to take into consideration that soft tissue dehiscence can occur in implants that are properly placed because of the lack of soft tissue management before or during implant placement. The majority of the soft tissue dehiscence occur in implants that are positioned in a bad way. And you cannot imagine how bad you can place the implant in whatever type of direction. We have implants that are placed in a bad buccal-lingual position, in a bad meso-distal position, in a bad apical-coronal position, so you can make mistake 365 degrees. This is why implant planification and surgical implant, guided implant are so crucial in reducing all possible mistakes, not because we are not good and talented surgeon, but because even a small mistake can lead to a huge aesthetic failure in the end for your patient. And so basically, this is the decision making that I'm going to describe you today. It seems huge, and it is quite huge, but as I was saying, we can do so many mistakes, and this is the schematic, let's say, decision-making tree to solve all possible mistakes you can face tomorrow in your daily practice. So basically, we start in an implant with a question, which is the implant position correct? If the answer is yes, it means that the implant was placed in a good way, but without taking care of the soft tissue management during the implant positioning. So now we have to check the papilla dimension to understand what we can do to solve this type of complication. And if we have a good amount of interproximal soft tissue, like in this case, in which, as you can see, we have a class 1, because we don't have an apical shift of the mucosal margin, but we have the lack of soft tissue thickness that create this area of gray, which is the metallic that is visible through the thin alveolar mucosa. This is not a big defect, but it's something that the patient doesn't like. And I can tell you that when you have an horrible baseline situation, when the aesthetic is completely destroyed and the patient comes to you and you ended up with a good result, not optimal, but a good one, the patient is happy because the baseline was so bad. But when you have small defect and the patient is complaining about the small defect, you have to end up with a perfect result. Even a small mistake is capable to create something which is even worse than the baseline situation. So small surgeries sometimes are not easier than bigger ones. And in that specific case, as you can see, we have this class 1 defect with a quite good amount of interproximal soft tissue. So according to our decision-making process, I don't have to remove the crown, we just make some improvement in the distal aspect of the papilla that was a little bit over-contoured. And this is the day of the surgical procedure. You see the high smile line of the patient that during the smile show this aesthetic failure. And please look at the distal papilla. The distal papilla of the central incisor is so thin. It is high, 3 millimeter high, but in buccal lingual dimension is very, very thin. And this is something which is really crucial to understand, because we can increase the soft tissue thickness not only in the buccal aspect but also the interproximal level. So basically, in this type of procedure, I need to raise the flap because I wanted to position a connective tissue graft below that is going to increase the soft tissue thickness in this area, in the buccal aspect, and also in the interproximal aspect, to increase the volume of the interproximal soft tissue, especially to the distal papilla. So I'm raising an envelope type of flap. Every time it's possible, I go for an envelope type of flap because without vertical releasing incision, I have the best possible vascular supply for my surgical papilla. But this is something that is possible when I don't have to provide a huge coronary advancement for the flap. Because if I need a huge coronary advancement, the vertical releasing incision are really important to provide a better coronary advancement for my flap. Why do I need to raise the flap? As you can see in the article, what we said is that you don't have to remove the crown and you can perform a coronally advanced flap or a tunnel procedure. This is because we wrote the article along with our friend at the Michigan University that they are more used to perform tunnel technique. And so, to be fair, we wrote that you can also do tunnel. But why I'm not going to make tunnel in that case? As I was saying before, if I'm going to end up with not the ideal result, it's going to be a nightmare for the patient. And this can happen, for example, if you have the connective tissue graft exposure. Connective tissue graft exposure, for me, is one of the worst complications of this surgical procedure. I'm not used to perform big GBR procedure. I'm not an oral surgeon, I'm a periodontist, and I play with soft tissue. And this is because I'm always scared when I do huge bone regeneration that if something goes in the wrong way, then you can end up with a worse situation than the basal. With soft tissue, it's really rare to have huge complication, and the majority of the case, complication means that you are not able to cover the root or to increase enough the soft tissue thickness, but you don't have a worse situation than basal. But I can tell you that one of the worst complications that can occur is the connective tissue graft exposure in a highly aesthetic case. Because when the connective tissue graft comes out from your flap or from your tunnel, then you have the keloid appearance, which is a scar of the connective tissue that heals like a free gingival graft, which is horrible in the central incisor. In a patient that was complaining for the transparency and now present a keloid, this is a nightmare. Also because the surgical procedure to correct the connective tissue graft exposure is more difficult than this surgical procedure. So how to avoid the connective tissue graft exposure? To avoid the connective tissue graft exposure, what do you need to provide is the complete coverage of the graft with the flap that is stable and tightly stabilized around the convexity of the crown of the implant supported restoration with the complete stability of the bleeding. Only in that way you can be quite sure that the graft is going to remain covered thanks to the complete absence of tension in your flap, and it is not going to be exposed. So this is exactly what I did in that case. I raised my split thickness flap, obtaining the complete passivity of the flap that is going to cover the connective tissue graft, because at the end, at the beginning, the position of the mucosal margin was in the right position, so I didn't have to coronally advance to cover something. I just have to coronally advance my flap to cover completely the connective tissue graft that is going to increase the soft tissue thickness, masking the transparency and improving the emergence profile of the implant-supported restoration in the supracrestal portion of the soft tissue. So now I'm in the palate. You will see only this harvesting procedure. This is the free gingival graft with a desepithelialization in a second step. No other alternatives on my end. This is the easiest surgical procedure on the palatal side, the safest, and the one who allows me to obtain the best quality of the connective tissue, because I'm harvesting the connective tissue which is immediately subepithelial. The more you go deep into the palate, the worse is going to be the quality of your connective tissue graft. The more you go deep into the palate, the more you will get fatty and glandular tissue. And when you harvest fatty and glandular tissue and you place it above your implant or your root or whatever you're treating on the buccal aspect, this is going to shrink. While this connective tissue graft, which is made of pure collagen-dense fiber, is not going to shrink at all. It's going to remain stable in that position, and it has the capability to stabilize the flap in the coronal position. This capability, this characteristic is unique from the connective tissue graft. We don't have other possible collagen matrices nowadays that are capable to stabilize the flap in the coronal position. This is unique from the connective tissue graft. Collagen matrix can, for example, increase the volume of the soft tissue, increase the soft tissue thickness, but only if the flap is stable by itself in the coronal position. So as you can see, the thickness of this connective tissue is, in order to obtain between the flap and the connective tissue graft 2 millimeters of soft tissue thickness at the end of the surgical procedure, because we know that if we have 2 millimeters of soft tissue thickness, we can mask to the human eye the transparency of the metallic below. This is something that our ITI president, Ronnie Yu, told us in some article that he wrote on the masking prosthetic component below the soft tissue. And he told us if you have more than 2 millimeters of soft tissue thickness, you cannot see below the tissues. And this is exactly what I'm doing. I'm increasing the soft tissue thickness up to 2 millimeters between the covering flap and the connective tissue graft to avoid the transparency and to increase the volume of the soft tissue. As you can see, I extended my connective tissue graft to both mesial and distal, especially to the distal papilla, because if you remember the initial situation, I told you that the distal papilla was weak, not in height, but in volume, in thickness. So if I extend the measured distal dimension of my graft, I can increase the soft tissue thickness also at this level. And you see now the profile of the implant supported restoration, how it looks with the connective tissue graft, which is extended in an apical dimension above the buccal bone. And now I coronally advance my flap. I was able to remove all the muscle insertion from the inner aspect of my flap. I have performed the frenectomy from inside, removing through the deep and the superficial split thickness incision the muscles in between, that were the muscles that belongs to the frenulum, in order to remove all the tension and to obtain a flap which is passive. And now, with the sling suture, with the suspended sling suture, I tightly adapt my surgical papilla above the anatomical disepithelialized papilla that will represent the vascular bed for the surgical papilla. So surgical papilla, the triangular shaped surgical papilla, are adapted above the anatomical one, and with the sling suture, I'm capable to tightly adapt the margin of my flap around the convexity of the teeth and around the convexity of the implant supported restoration. This is going to completely stabilize the bleeding, which is another crucial concept in our surgical procedure. At the end of the surgical procedure, I don't want to see any bleeding at all. Until I see some bleeding, I'm not going to stop suturing, because the complete absence of bleeding means stability of the blood clot. And stability of the blood clot is one of the most important biological aspects in periodontal surgical procedure, and therefore in soft tissue management around implants. So you see, when I pull the suture, I always use PGA suture material. Whatever suture you will see in the video, they are PGA 6 for the sling suture or 7O for the connective tissue graft. This is a resorbable material which has the characteristics to be resistant, but on the other side soft. So when I pull the suture, I don't have the risk to break the soft tissue. If I pull too much, I will break the suture. That costs a lot, but it's better to break the suture instead of the soft tissue, especially at the end of the surgical procedure. And so you see, no bleeding at all. The mucosal margin at the level of the implant supported restoration is coronally displaced to cover the connective tissue graft that is going to remain completely covered and is going to increase the soft tissue thickness that is going to mask the transparency for this patient. And as you can see, this is what happens on the palate. There is no almost bleeding anymore. I always take care of the palate when the buccal aspect is finished. And in that specific case, I don't even have to apply any suture, just a collagen sponge and this cyanoacrylate, which makes this procedure very easy and no time consuming. It's a kind of glue that you can apply on top with or without the fibrin sponge on the palatal aspect that becomes stiff, and it is also capable to control the bleeding. I will recall the patient 2 weeks later for suture removal. I never recalled the patient before 2 weeks. And during that time, the patient is going to perform chlorhexidine application with the liquid, 0.12, 3 times a day for 2 weeks. Not gel, I just like the liquid, because otherwise with the gel, the patient is going to touch the surgical area, which is something that I don't want at all. I don't want the patient is going to look, and this is how it looks, the healing. Please look on the profile. You see, now it's completely different. And if you look, comparing the before with the after, on the distal papilla, look how it increased in volume. So, and this is obviously the X-ray showing that what I'm going to describe you about the treatment of this defect is around well-osteointegrated implant without any signs of mucositis or perimplantitis. We are simply dealing with aesthetic complication mainly in bad implant position, but not without any bacterial or degrees of inflammation. This is another case in which we have a slightly apical position of the mucosal margin. The implants are both well osseointegrated. The crown is in the right position. The papilla were quite good, so I can simply raise a flap, which is in that case a trapezoidal flap, because I need some more coronal advancement, because I have an apical shift of the mucosal margin differently from the previous case, and the connective tissue graft should be completely covered by the coronally advanced flap that is going to change the position of the mucosal margin and is going to completely cover the connective tissue graft below. And this is the healing, in which you can see we have the mucosal margin at both lateral incisor, which is now at the same level in a more coronal position with respect to the margin at the level of the central. And from an aesthetic point of view, we wanted to have the lateral incisor shorter than the central incisor and the canine. So with a simple, straightforward surgical procedure, in this case that belongs to class 2, we were able to solve this aesthetic complication for the patient, restoring the right situation. What happens if we don't have 3 millimeter in height of peri-implant papilla? We cannot simply perform the surgical technique because we don't have enough interproximal soft tissue to ensure the stability of the coronally advanced flap. And this is something that we learn from mistake. As I was saying you before, when we started to treat these cases, in some cases we had good results, in other cases we didn't have good results. And this was because we didn't understand that the difference between these two cases and the difference between the final result was related to the amount of interproximal soft tissues. We know that the interproximal soft tissue are important, but we didn't know how to increase them. And what we learned, by chance again, it was that when you remove the crown, this happened because one of the first patients that we were treating was one patient of my practice. I work with my dad. He is a dentist. The father of my dad, my grandpa, was a dentist too, so I have an heritage of dentistry at home. And my father was the first one who started to place the implant in our practice. And at the beginning, it was just focused on bone, and it was just focused on osseointegration. So he didn't take care of the soft tissue management. Not because it was not a good dentist, he's my dad, so it is for sure, he is for sure, but because he didn't know about that. And so he had this case with the huge soft tissue lesions in a central incisor, and then bring the patient to university and ask professor if he can do something to improve the situation. So I bring the patient and I ask what we can do, and the patient said, and the professor said, we have to remove the crown to check the implant head. And during the crown removal, I broke the crown completely. But since we are a perio department, we didn't have at that time the good restorative material to provide the patient a nice provisional restoration. And so, and I'm not good in prosto at all, so I did for the patient an horrible short provisional restoration, and I asked the patient, please come back in a week and I will give you a better one. Just sorry, please forgive me. And the patient said, okay, it's not a big deal, I will come back in a week. And when the patient came back a week after, I looked, and the interproximal soft tissue were much better than 1 week ago. So I called professor and I said, look how the soft tissue improved. So he asked the patient, can you please keep staying with this short, horrible provisional crown for 1 week? And the patient said, okay, I will. I'm not smiling during this day, but anyway. And then, after 1 week, it came back and the soft tissue were even better. So we realized, and then we started to perfectionate this technique, that once you remove the crown, and if you apply a narrower abutment and a short provisional crown, not in contact with the soft tissue, they start to grow and occupy the space that was previously occupied by the crown and the abutment. It is not a huge coronal increase of the soft tissue, but it's an improvement in the width of the soft tissue. So the final amount of interproximal soft tissue that you have that will provide the vascular supply to the surgical papilla increased dramatically, providing you enough vascular supply for the surgical papilla of your flap. So once we understand this concept, we try to make it as much as possible reproducible for our patient, and we publish this technique, which is called combined prosthetic and surgical approach. Because if you look at this case, if I'm trying to cover this recession, I have to place the connective tissue graft at this level. And to cover completely the connective tissue graft, this is the small amount of interproximal soft tissue that I will have coronal to the connective tissue graft for my surgical papilla. So for sure, in that case, what is going to happen is that my flap is going to shrink because it is not capable to receive enough vascular supply. If the flap shrink, I can be either very lucky. What does it mean is that the papilla shrink, the brachial margin of the flap shrink, the connective tissue graft remain exposed, and it is going to heal as a scar, as a keloid, but it is going to cover the recession or cover the soft tissue deletions with not the ideal aesthetic situation, but at least covering something. If I'm not lucky, the papilla are going to shrink, the brachial aspect of the flap is going to shrink, the connective tissue graft remain exposed and go into necrosis. So nothing is going to happen at the end of my surgical procedure. I'm going to have the same baseline situation with some scar because of the flap elevation. So to ensure the stability of the flap in the coronal position, we understood that if you remove the crown, you place a narrower abutment. At the beginning, we simply relined the abutment like when you prepare a natural tooth. Now we provide a customized narrower abutment with a short provisional crown, and then we let the soft tissue to mature for, let's say, between 2 and 4 months. And the day of the surgical procedure, working without the crown in position, you can also take advantages of the occlusal aspect of the interproximal soft tissue that can be disepithelialized and can provide the vascular supply to the surgical papilla of the flap. So the combined prosthetic and surgical approach allow to position the connective tissue graft in the right position, which is 1 millimeter more coronal to the final position. So we coronally also advance in excess our flap in order to allow the prosthodontist to have more tissue in the coronal position that will be conditioned in the second prosthodontic phase after the healing of the mucogingival surgery. But at the same time, we allow the stability of the flap in this coronal position thanks to the increase of the vascular supply that derives from the interproximal soft tissue. And so every time we have these type of cases, we started with the pre-surgical prosthetic phase that lasts between 2 and 4 months. When you don't see any improvement between one visit And the follow-up, you can say, I have gained the soft tissue as possible, so now I can go for the surgical procedure. The surgical procedure consists on the same trapezoidal flap approach with the 2 horizontal incisions and the 2 vertical ones. As you see, the flap design is performed with 2 vertical releasing incisions that are extended 1 millimeter into the alveolar mucosa. And I just wanted to underline this concept because many colleagues are scared by vertical releasing incision. I love vertical releasing incision because vertical releasing incision is performed in the proper way, allow you to obtain a huge coronary advancement, allow you to cover whatever you want without any problems in terms of vascular support, because vertical releasing incision interrupt the vascular support when they are performed into the alveolar mucosa. These vertical releasing incisions are really limited in alveolar mucosa. I just make the vertical releasing into the keratinized tissue and 1 millimeter into the alveolar mucosa, so there is almost no vascular supply interruption. And they have been performed at the beginning with the flap design, which is made only with the tip of the blade without touching the bone. And then the flap is raised completely split thickness, avoiding any periosteal damage with the blade. So I never experienced scar formation at the level of the vertical releasing incision. This is the desepithelialization of the anatomical papilla that derives from the pre-surgical prosthetic phase and that can be desepithelialized toward the palatal aspect. So you see that the surgical papilla of my flap does not only go coronal, but also toward the palatal side. So I obtained this huge coronary advancement thanks to the vertical releasing incision. Then the same harvesting procedure, free gingival graft, desepithelialization in a second step. The thickness of the graft is to end up with 2 millimeters of soft tissue thickness between the flap and the graft at the end of the surgical procedure. You see, the quality is white, only collagen dense fiber, no fatty, no glandular tissue. And I stabilize it through this mattress suture, 1 millimeter more coronal with respect to the final position, completely within the recipient bed, using the abutment that is capable to withstand the connective tissue in that position. And then I start closing the flap, starting from the vertical releasing incision, reducing all the tension before the last sling suture. And you see the flap is completely covering the graft, which is a crucial concept. And now you see the flap is already in the final position. This is another concept which is very important. It's different from the tunnel. With the tunnel technique, you always struggle in trying to maintain the tunnel in a coronal position, anchoring with the suture, with the composite pin, your flap, which is going to be forced to stay in a coronal position. While here, the flap is already stable in the coronal position without the sling suture, because it's completely passive, without any tension. You saw the superficial split thickness incision that was performed, maintaining the blade parallel to the inner aspect of the alveolar mucosa, removing all the muscle insertion. And this is another crucial concept, because every time I spoke about coronally advanced flap, I know that people is thinking about reducing the vestibule depth. And this is because people is used to coronally advance the flap with GBR procedure. And yes, I agree with you. If you have to perform a GBR procedure, I always tell when I saw him poorest Urban, that you have to coronally advance your flap with so many muscles inside. And this is why he's struggling, inventing the iceberg, the sausage, the garage, and in the name of his technique, in order to recreate keratinized tissue after the bone regeneration procedure, because when you, hi, ciao, there is a young dentist under the table. When you coronally advance a flap to cover a bony block or titanium membrane with pin screw, you need a flap which is thick enough to withstand the first intention closure. And also when you raise this flap, you need to raise this flap in a full thickness way, because you need to make the bone to be completely exposed. In all of these surgical procedures, what you are going to see is a split thickness flap elevation, removing all the muscle insertion from the inner aspect of the alveolar mucosa. So when I coronally advance my flap, I'm not coronally displacing the muscles. So the vestibule depth is reduced when you coronally advance the muscles. If you simply take advantages of the fact that the alveolar mucosa, once it is completely without muscle, is made of elastic fiber. So I just take advantages of the elasticity of the alveolar mucosa. And thanks to the suture in the most apical extension of the vertical releasing incision performed taking the periosteal anchorage, I stabilize the bottom of the vestibule, and from this apical bottom of the vestibule, I stretch the alveolar mucosa to cover, in that case, the implant or around teeth to the recession, without any vestibulum depth reduction. In some cases, obtaining even an improvement of the vestibule reduction. We are not going to discuss about periodontal patients. We are not going to discuss about the treatment of gingival recession in the lower anterior mandible, and it's a pity because it's one of the surgeries that I like the most, but it's not the topic of today. But I learn a lot in treating this area of the mouth, because in the majority of the case, when I start my surgical procedure and I pull the lip of the patient, the muscles of the lip are perpendicularly inserted at the level of the gingival margin. What does it mean? That the vestibule depth is 0. And I'm capable to coronally advance the flap, verticalizing a flap that derives from the alveolar mucosa of the lip, verticalize, and then coronally advance the flap. And at the end of the surgical procedure, I have 8 millimeters of vestibule depth, starting from 0. So I'm not reducing the vestibule depth, I'm creating the vestibule depth with the coronal advancement of the flap, performed in that way, removing all the muscle insertion from the inner aspect of the alveolar mucosa. And so look at the healing. Now we have the good scalloping of the margin and an increase of the interproximal soft tissue. What happened after the surgical procedure? After the surgical procedure, the patient is still wearing a short provisional crown, not in contact with the soft tissue, for, let's say, 4 months, because I wanted to have an undisturbed soft tissue healing that takes around 3-4 months at least. Then the prosthodontist can start the second prosthetic phase, which is called conditioning phase, in which he or she started to recreate the right scalloping of the margin of the soft tissue, and at the same time guiding the interproximal tissues to grow in a coronal position. And so this was the final result, and this was one of the cases that was part of an article. If you don't have any papilla at all, so if you are in subclass C, the worst clinical scenario, you cannot try with the same combined surgical approach, because If you don't have papilla, even if you remove the crown, place a short provisional restoration, they will not grow enough to withstand the flap in the coronal position. So in a casing like this one, in which the implant, as we already discussed, is placed in the right position because it is not too buccally displaced, but we are the complete lack of both papilla, especially the distal one. We don't have so many possible alternatives. So we started to think what to do in this type of defect, because again, when you treat this type of defect, the only alternative is to extract the tooth, the implant, not the tooth, the implant. Because if the patient asks for better aesthetics, the only alternative solution is implant extraction, but then it's not going to be an easier solution or an easier treatment plan, especially because these implants are well osseointegrated, so it's not easy to remove them in the majority of the case. And then you have to deal with the lack of bone, the soft tissue management, a new implant. So it's something that requires a lot of time, skills, and money for the patient. So I always try to think possible alternative solution to keep the implant in position, because there are no bacteria, there is no infection. And so my first choice is always to try to keep the implant. So again, thinking about our mucogingival procedure, we realized that we have one technique that we use to apply to increase the volume of the soft tissue in a dentulous area for pontic restoration. When you have to make a bridge with a pontic, but you don't have enough soft tissue, especially in the past when we didn't have the implant. I'm so young, so there were implants, but you have to increase the volume of the soft tissue, and we use a technique that is called connective tissue platform technique, which is a technique that creates an area in the occlusal aspect of the edentulous area that is disepithelialized, and above which you can apply a layer, or sometimes even more, of connective tissue graft, and then you completely cover with the coronally advanced flap. And this technique can be applied also in these cases in which we don't simply need to coronally advance the flap and increase the buccal soft tissue thickness, but we need to change the position of the interproximal soft tissue. We need to increase the interproximal soft tissue height. And so this technique can be applied treating this area as if it is an edentulous area. It's an edentulous area with a hole in the middle. So basically, this technique consists in the execution of the vertical releasing incision, because we need a huge coronal advancement, because we are going to increase the apicocoronal dimension of the soft tissues, placing the connective tissue graft above the occlusal platform. So every time I need a huge coronal displacement, I take advantages of the vertical releasing incision. And also because when I make vertical releasing incision during the flap closure, I can anchor the periosteum in the most apical extension of the vertical releasing incision to stabilize the bottom of the vestibule and reduce the risk of vestibule reduction. The flap consists in the vertical releasing incision and in a first horizontal incision on the buccal aspect, connecting line angle of the two adjacent teeth neighboring the edentulous area. The flap is raised split thickness, full thickness in the central portion, introducing the periosteum elevator directly into the sulcus, And then, as usual, split thickness. You see the blade at the level of the vertical releasing incision is always beveled. Beveled means angulated 45 degrees, never cutting the periosteum. These avoid the risk of scar formation. And as you can see, the vertical releasing incisions are mainly in keratinized tissue and descended only 1 millimeter into the alveolar mucosa to reduce as much as possible the vascular supply reduction. This is the deep split thickness incision performed taking the blade parallel to the bone, and then the superficial one maintaining the blade parallel to the inner aspect of the alveolar mucosa. So I'm removing all the muscle insertion from the inner aspect of the alveolar mucosa. In this patient, a previous attempt of bone regeneration was performed, so this amount of biomaterial that was embedded into the muscles and the connective tissue was removed along with the muscles of the frenulum, so a frenectomy from inside, until, as you can see, the alveolar mucosa was completely free from tension and can be coronally advanced in excess. Now I can start performing the second incision on the palatal aspect, connecting line angle with line angle and delimiting the occlusal platform that in a real edentulous area is completely made of epithelium and connective tissue. Here we have the hole because of the implant in the middle, but we will have enough connective tissue mesial and distal with respect to the implant to facilitate the graft fixation above the platform. So we are basically going to completely submerge the implant, placing the connective tissue graft on top to allow the interproximal soft tissue improvement. Now we go on the palate, and I'm going to harvest some connective tissue graft with the previous surgical technique, the free gingival graft and desepithelialization, and also, in that specific case, connective tissue graft that derives from the tuberosity. I usually like to harvest the connective tissue graft from the hard palate, but in this specific case, in which I need a huge volume of soft tissue, the shape of the connective tissue graft that derives from the tuberosity can perfectly fit, in that case in the distal aspect, to increase the volume of the distal papilla. So usually I don't like to go to the tuberosity because of the risk of hyperplastic reaction of the tuberosity, but in cases in which I apply this platform technique, the tuberosity can be of help because of the thickness of the tissues, and it is going to be completely covered by the covering flap, reducing the risk of hyperplastic reaction during the healing. So now I'm going to prepare the 3 free gingival graft that should be desepithelialized. This is the most difficult part of the surgical technique because the harvesting phase is very easy on the palatal side. Then it's a little bit more challenging when you have to make the desepithelialization that should be performed using a new blade, the light of the chair perpendicular, a drop of saline, and removing slices of epithelium. It's like sushi. It's not an external peeling, but it's a slice of epithelium. In this way, you are quite sure, if you remove a slice, that you are removing all the epithelium. As you can see, I was planning the root of the adjacent teeth that presented gingival recession. According to Cairo, these gingival recession are RT3, so not possible to be covered because of the lack of interproximal tissue. Just remind this because at the end you will see the healing. When I perform the root coverage, I always perform root planning with Gracie Curette, and then I apply ADTA gel to remove the smear layer from the dentin tubuli. And so I did the same for the central and the lateral incisor. And now I'm fixing my connective tissue graft, taking anchorage to the platform, to the base of connective tissue graft that derives from the disepithelialization of this area that was delimited by the two horizontal incisions, parallel, one on the buccal and one in the apical. And since I need to reach this level in terms of coronal improvement of the tissue, you see that the position of the second layer of connective tissue graft applied into the platform is because I wanted to cover the gingival recession on the neighboring teeth. So I need to coronally advance the flap and cover the cemento-enamel junction at the interproximal level on the two adjacent teeth neighboring the edentulous area. This will allow to recreate the peri-implant papilla for the implant that is in position. So now I have to try to cover everything by first intention. So I start with some single suture, single interrupted suture that put in contact the buccal flap with the, not the palatal flap, because I didn't raise the palatal flap, but I just raised a little bit to facilitate the graft fixation. Then I go back to the vertical releasing incision, positioning the two trapezoidal surgical papilla above the anatomical one, closing the vertical releasing incision on both mesial and distal aspect, and then try to improve to perfectioning the first intention closure in the other aspect. This is the sling suture, as you can see, to obtain the tight adaptation of the surgical papilla above the anatomical one and the adaptation of the margin of the flap around the convexity of the lateral incisor. And then some more single interrupted suture in the occlusal aspect to obtain the complete graft coverage. So the connective tissue graft are going to receive the vascular supply from the platform and for the covering flap that is completely covering the graft. So now I will place in position a Maryland bridge that is going to be not in touch with the soft tissue and is going to be maintained for at least 3-4 months just to let the undischarged soft tissue heal. And after 4 months, we can rescue the head of the implant with this guided punch that has been planned with the previous scan in order to just remove the soft tissue that are covering the implant head, maintaining untouched the interproximal soft tissue. So once we reach the head of the implant, unfortunately, we have to throw it away. It's a waste of pure collagen-dense connective tissue graft, but we cannot use it in any way. And we can place the provisional crown to start the conditioning phase because we have now a flat edentulous area, so we need to push in an apical direction the soft tissue margin, and at the same time, with the conditioning phase guiding the regrowth toward the coronal aspect to fulfill the interproximal space of the interproximal soft tissue. And this was the final healing, as you can see, with the improvement in the soft tissues that allow to increase the buccal volume, to increase the interproximal soft tissue, recreating the peri-implant papilla. And if you look, as I'm saying, I'm a periodontist, look at the gingival recession that was affecting the two adjacent teeth. They are theoretically not possible to be covered because of the lack of the interproximal support, But with this technique, you can also increase the coverage of FT3 recession defect. And this is the smile of the long term that allow nowadays to have long-term results with more than 10 years of follow-up with this mucogingival procedure. So now we move to the second part of the decision-making process, because we have to deal with the majority of the case that belongs to implants that were placed in the wrong position. And so the implant is placed in a wrong position.
So excuse me, can we have like a tea break? Our tea break? Yeah.
Okay, so we can start after the...
Yeah, the tea break, yes.
Okay, yes. So do you want to have break and questions now? Okay.
Thank you very much.
Okay, you're
Vâng,
welcome.
kính mời quý thầy cô, quý tổ viên, chúng ta sẽ có 30 phút để giải lao.